Hello, my name is Justin Corcoran, and I will be giving the Spy Review lecture on plants. Before we really jump in, we'll do a really brief overview. What's important from this lecture is to learn the classes, the symptoms associated with the plants in each class, and some of the specific treatments where those exist. We are not going to talk about every plant. In the textbook for medical toxicology, there's a table with more than 150 plant species, and that would just not be feasible to go over throughout the course of this lecture. However, we will review just a little bit under a third of those in their appropriate categories. And I do want to mention before jumping into this from a clinical perspective, you really have to be careful with plant exposure. So in 2023, plant exposures made up about 2% of exposures reported to the nation's poison centers, but they didn't even hit the top 25 list for the categories of fatal exposures. So we know that plant exposures generally follow a more benign course. However, in sporadic cases, there are still lethal outcomes, and therefore you really need to maintain some index of suspicion for these plant exposures because serious outcomes do occur from time to time. So we're really trying to pick out the couple of cases that have that kind of worse exposure, larger volume, more lethal toxin, so that we can triage patients appropriately. And with that, let's begin. The first class that I'd like to go over are the tropane alkaloids, and some examples of plants in this class are going to be the deadly nightshade on the left, and then the Jimson weed on the right. And throughout the course of this lecture, I'll provide the Latin names more for reference than something that you necessarily need to commit to memory. These are called tropane alkaloids because the compounds associated are atropine-like compounds. So they create atropine, hyoscyamine, scopolamine. These occur in various proportions in the plants in this category. And all of these compounds are muscarinic antagonists, and therefore they cause clinically an anticholinergic or antimuscarinic toxicity. You'll be familiar with the um, mnemonic for this: blind as a bat, red as a beet, hot as a hare, full as a flask, tacky as a fur coat, and mad as a hatter. And that just refers to some of the symptoms that occur: mydriasis, flushing, hyperthermia, urinary retention, tachycardia, and delirium. As far as management goes, a lot of these patients can be managed with observation only. They do tend to develop some agitation and delirium. A lot of times that can be managed with the behavioral modifications, things like a dark room, quiet, calm environment, frequent redirection, and in some cases, bladder catheterization as urinary retention tends to be one of the things that produces a lot of agitation in these patients. For patients that require pharmacologic management of their delirium and agitation, you have two primary options. The first primary option is anticholinesterase therapy, and the second primary option would be benzodiazepines. Benzodiazepines are reasonable for the use of anticholinergic um, delirium. However, they don't fix the underlying problem. They just make the patient sedated enough that they're more easy to manage until the atropine or similar compound metabolizes off. And you can imagine that some of these patients require multiple doses or sometimes escalating doses of benzodiazepines, which is sometimes not optimal therapy. And so we have anticholinesterase therapy available as an option. These are acetylcholinesterase inhibitors that work to increase the amount of acetylcholine at the synapse. This overcomes the blockade of the muscarinic receptors and actually completely reverses the delirium. Classically, we've used physostigmine for this indication. Physostigmine is available as an IV medication. It acts rapidly to reverse delirium. It has a relatively short duration of action, usually around an hour, and therefore patients do sometimes require repetitive dosing. Since physostigmine has been on national shortage recently, we do have the option of using rivastigmine either orally as or as a patch, and have had some success with this in the management of pharmacologic-induced anticholinergic delirium, and it would be anticipated that this would work similarly for a patient poisoned with a plant-derived source. Next, we'll talk about the cholinergic alkaloids. This is going to be something that you'll be less likely to run into, but a couple of examples of plants in this class. First would be the calabar bean, Physostigma venenosum. This is the plant from which physostigmine is derived. There's also the betel nut, which is chewed in some parts of the world. And these produce a couple of compounds. Physostigmine, as I mentioned, comes from the calabar bean, and then arecoline is the primary um, cholinergic alkaloid associated with the betel nut. I also include on here pilocarpine. I did not provide a picture of the plant that pilocarpine is derived from, as I wasn't able to find an open source version of this, but you can easily search this on Google or any other search engine to find a picture of the plant that this comes from. What is important to note is that physostigmine is an acetylcholinesterase inhibitor. Arecoline and pilocarpine are direct muscarinic agonists, and therefore they produce a similar toxicity, but the mechanism is just a little bit different. In terms of clinical manifestations, you see typical cholinergic manifestations. So that would be bradycardia, wheezing due to bronchospasm, and then bronchorrhea or excess respiratory secretions. I put these at the top because these are sort of the more severe manifestations. You do end up with a lot of secretory problems, so salivation, lacrimation, diarrhea, diaphoresis. So those will be a common part of the poisoning. However, they're not necessarily the severe or life-threatening manifestations as the heart and lung manifestations are. In terms of management, your go-to is going to be atropine for this. Sometimes this requires escalating or large doses depending on how much of the toxin the patient was exposed to. And then in rare cases, you may require sedation with benzodiazepines, propofol, and or mechanical ventilation if they're not improving with atropine. Moving on to our next class, we have the psychotropic alkaloids. These would be things that produce hallucinations. A couple of examples in this class are the morning glory over on the left and the mescaline or peyote cactus over on the right. A couple of compounds here. So lysergic acid over on the left is a derivative of the morning glory, and then mescaline over on the right is the derivative from the peyote cactus. And basically, these are going to cause hallucinations, potentially less so than you might imagine from a related compound LSD, which is more of a recreational drug. And then often, because these are serotonergic agents, you get some of the symptoms that you expect from serotonergic excess, like sweating and vomiting. Generally, these follow a fairly benign course. Your management is going to be mostly supportive care, fluids, and then for patients that require any pharmacologic intervention, that's mostly going to be the use of benzodiazepines. Moving on to the next category, we have the CNS stimulants, and there are a number of different things in this category. So starting over on the left, we have khat derived from the plant Catha edulis. Over on the right, we have the bitter orange or Citrus aurantium. Ma Wang on the left is a ephedra species that deserves some discussion. And then over on the right, we have the Yohimbe or the Posinistalia yohimbe, which is derived from a bark of this plant. The compounds in this category, uh, cathinone is derived from khat. You'll notice that that is an amphetamine-like structure, so a beta ketoamphetamine, and it produces an amphetamine-like toxicity. Over on the right, synephrine is the major derivative from the bitter orange plant, and you'll note a similar structure to some of our endogenous catecholamines like epinephrine and norepinephrine, and so can produce a similar type of toxicity in large ingestions. Down on the bottom left, you have ephedrine. This is a derivative of Ma Wang and it is historically interesting in that it produced a lot of deaths from supplement use. back in the late 1990s and early 2000s, and subsequently was banned as a supplement in the United States. And then on the bottom right, you'll notice that yohimbine has a fairly different structure. It doesn't share that phenylethylamine backbone. Yohimbine produces a stimulant type toxicity, but it does it by a different mechanism of action. So all of the phenylethylamine compounds tend to work on the catecholamine system, either to promote release of catecholamines or to block the reuptake of catecholamines. Yohimbine is actually an alpha 2 antagonist. And so you might be familiar with alpha 2 agents such as clonidine or dexmedetomidine, which are alpha 2 agonists. Those produce uh, inhibition of the central nervous system sympathetic outflow. Him being an alpha 2 antagonist acts opposite to that, where it enhances the sympathetic outflow of the central nervous system. And so you can imagine that clinical manifestations from these agents are going to be similar, even though the mechanism of action is somewhat different. You will often end up with tachycardia and hypertension. In terms of some of the more serious agents, ephedra has been associated with myocardial infarction and stroke, and yohimbine has a bit of an association with those as well as the manifestation of seizures. In terms of management, here we're going to again lean on benzodiazepines. There's a question about whether there may be a role for antihypertensives. And what I'll say about that is generally we are going to try to use benzodiazepines for the bulk of the therapy for these patients. However, if the patient is poisoned to the degree that they have a hypertensive emergency, that would be something like a hemorrhagic stroke or a myocardial infarction, which admittedly would be uncommon with a plant-derived exposure, then it may be reasonable to use direct-acting antihypertensives as part of the management, but not as the sole management. We should only be using these in conjunction with benzodiazepines. Next, we'll move on to miscellaneous other alkaloids. This is a bit of a catch-all group. Over on the left, we have strychnine. I included both the plant and the kind of nuts that come out of this, as you could see both depictions in a testing scenario or in a real-life scenario. And then over on the right, I have the Chondrodendron tomentosum, which is the curare plant. And then a final example is Ipecac, which is on the left side of this slide. So the associated toxins in this group, emmetine and kephaline, over on the left are derivatives of the Ipecac plant. In the middle, you have D-tubocurarine, which is a derivative of the curare plant, and then strychnine is a derivative of the Strychnos nux vomica plant. These all do something a little bit different, so we'll go over that now. Mentine and kephaline are notable for producing vomiting, and you'll be familiar with Ipecac as the syrup of Ipecac that was once used pretty prominently in toxicology for induced emesis for gastric decontamination. We don't use it for that purpose anymore, but it is worth noting that you could sporadically see a case of cardiomyopathy. This is a manifestation of chronic ipecac abuse, which is sometimes a vehicle by which people manifest the symptoms of an eating disorder. Curare is a non-depolarizing nicotinic acetylcholine receptor antagonist, and therefore works at the neuromuscular junction and will cause a flaccid paralysis. This is similar to medications that we use clinically to produce a similar flaccid paralysis, such as when we're intubating a patient with rocuronium or vecuronium. The clinical manifestation of curare is similar. And then finally, strychnine is an interesting poison. It works in the central nervous system within the spinal cord as a glycine receptor antagonist. Glycine is a neuroinhibitory neurotransmitter and functions somewhat similar to GABA, but is isolated to the spinal cord where glycine receptors are located. Glycine receptors are important in reflex muscle arcs and for uh, sort of balancing the um, muscular motor activity that is caused both by reflex arcs and by intentional movement. And so when you antagonize this, you get essentially excess reflex activity and excess motor activity. This is manifested as rigidity. Patients will sometimes have rhizus sardonicus, which is sort of this facial muscle rigidity, and it's fairly common for patients to have spasmic contractions. And so patients are often described as being relatively fine as long as they're not moving, they're calm, comfortable in bed. And then if they have any sort of stimulus, they attempt to move or someone startles them, they will go into this spasm with strychnine. Moving on along to the management, again, because these compounds work a little bit differently. We'll talk about each one. In terms of Ipecac, this is really supportive care. If that is even necessary, ingestion of the plant material alone is unlikely to cause symptoms. It's more the concentrated syrup that is going to cause the vomiting symptoms. But if you needed them, antiemetics of any sort would be available to you. Curare, if a patient was seriously poisoned with this, there really would be no direct treatment. You would sedate and mechanically ventilate them until they improved. And then with strychnine, this actually is a serious poison in terms of the toxicity that you can get from the plant directly. And really, what you do with these patients is you put them in a quiet, calm, often dark environment so that you're not inducing any of that motor activity or spasm. It's reasonable to use benzodiazepines to sedate the patient slightly. And then if for some reason those things were not sufficient, you could consider neuromuscular blockade and mechanical ventilation, and that would temporize the situation until they were able to metabolize the compound completely. Moving along to the next category, we have cardiac glycosides. Cardiac glycosides are a huge category and could be their own separate lecture. So we'll touch on them fairly superficially here. There's going to be a bunch of examples. Over on the left, you have foxglove, the digitalis lanata variant. This is where we get digoxin from. On the right, you have the digitalis purpurea variant. Different oleander species contain cardiac glycosides. So on the left, you have the common oleander, and on the right, the yellow oleander. The yellow oleander is notable for being particularly toxic, and there's a lot of research into the management of yellow oleander due to this. Lily of the Valley on the left contains a cardiac glycoside, many cardiac glycosides, actually, the principal of which is convalitoxin. Kids tend to get into this fairly frequently, and we do not see a lot of clinically significant toxicity from this plant, even though it does contain cardiac glycosides. And on the right, you have the final example that I'll list for this lecture, the pong pong tree, which is notable for having been involved in sporadic cases of suicide. I won't include all of the toxins on this slide because there are many, many dozens of different cardioactive steroids. They all have a somewhat similar structure. Over on the left, you have what is called the aglycone steroid nucleus. Aglycone is the part of the chemical structure that does not include the sugar moieties that are appended to the end of the molecule. And so as a group, we tend to call these cardioactive steroids because it is more inclusive umbrella term. This comprises the classes cardinalides and bufadienolides. Mostly for this lecture, we're going to be talking about cardinalides because most plant-derived cardioactive steroids are cardinalides, and cardinalides are cardiac glycosides that have sugars appended to them. The animal-derived compounds that we won't talk about tend to be just the aglycone steroid nucleus. As an example, I have digoxin over there on the right, and you can see that there is that steroid nucleus on the right side of the molecule. Off to the upper right-hand corner, you see a five-membered lactone ring. This is how the cardinalide structure is defined by that five-membered lactone ring. And then off the left side of the molecule, you have its three sugar residues that turn the structure into digoxin. Clinical manifestations are what you would typically see from a cardiac glycoside, and you can see my separate cardiovascular pharmaceuticals lecture for a bit more of a discussion on this, but you have multiple systems involved. On an acute basis, from an electrolyte perspective, you're going to see hyperkalemia, and hyperkalemia, as I mentioned, every time I give a similar lecture, is a marker of toxicity, not the mediator of toxicity. And so we're going to be concerned about patients when they manifest any degree of hyperkalemia. Anything over potassium of 5 is going to be concerning that this patient is seriously poisoned. From a GI perspective, nausea and vomiting are extremely common. Sometimes people develop abdominal pain as well. Essentially, the majority of patients that are going to have any clinically significant acute toxicity are going to have some sort of GI symptom. And then I'll mention some other common things from a neurologic system perspective. You can sometimes see aberrant color vision and lethargy. And cardiovascular system is really where the bulk of the toxicity is exhibited. You can have arrhythmias. This can be any arrhythmia, but especially ventricular tachycardia. Bradycardia is common, and AV nodal blockade is also common. From a management perspective, if the patient is seriously poisoned, you're going to be giving them anti-digoxin antibodies. There is likely a variable response to this. So anti-digoxin antibodies were designed to bind up digoxin, not to bind up any other cardioactive steroid. And so we expect that there might be some cross reactivity, but we don't know how good that cross reactivity is going to be. And so there's an evidence base for yellow oleander, which is the only plant-derived cardioactive steroid in which this has been systemically studied and appears to be effective in that case. You do generally need high doses, possibly due to lack of perfect cross-reactivity between oleander and digoxin glycosides. It's also possible that the patients that were studied in the yellow oleander study just had much higher ingestion amounts because they were all with suicidal intent. So it's a little bit unclear, but generally the dose needed is much higher than for managing digoxin poisoning. And then there are case reports for many other plant-derived cardioactive steroids or cardiac glycosides with varying responses depending on the case report and the glycoside reported. Because of the prominent bradycardia, you might question whether atropine and pacing are available, and they are reasonable if you don't have access to anti-digoxin antibody therapy. They're also reasonable as a bridge to anti-digoxin antibody therapy. However, if you are requiring those uh, options, you generally should be trying to treat them with the antidotal therapy. There's always a question about insulin for hyperkalemia. You can do this, but it doesn't fix the underlying problem because, as I said earlier, hyperkalemia is not the mediator of the toxicity. It's just a manifestation of it. And then there's always a question about whether you can use calcium. There are animal models in which really significant amounts of hypercalcemia have been shown to produce hypotension in patients with cyanogenic or sorry, cardiogenic glycosides, but this doesn't pan out in humans. So if you feel that calcium is indicated, you can still go ahead and give calcium. However, as with insulin, it is not going to fix the poisoning. You still need to use other therapies to actually fix the toxic manifestation. Moving on to our next category, cyanogenic glycosides. Some examples here, cassava over on the left, and over on the right, I've got the apricot, or excuse me, apricot. Anything in the Prunus species or Prunus genus contains a cyanogenic glycoside. So that's things like prunes, peaches, plums, cherries. They all contain varying amounts of cyanogenic glycosides. The cyanogenic glycoside associated with cassava is linamarin over on the left, and amygdalin is the cyanogenic glycoside in the Prunus genus. And I've highlighted the cyanogen group there, and essentially this gets cleaved off slowly in the gut and then absorbed. Uh, so that is how this elaborates cyanide. In terms of clinical manifestations, the really large doses could produce a cyanide poisoning, and so you get things like nausea and vomiting. Lactic acidosis is the classic manifestation. Because this requires cleavage of that cyanogen moiety in the gut, it takes hours for this to develop, and generally is not common at all in plant-based poisoning. However, you do sporadically see people with suicidal intent overdoses, especially with things like very large amounts of apricot kernels that can develop a mild to moderate cyanide like toxicity uh, by doing that. I should note that cassava has a chronic poisoning associated with it, so this requires inappropriate preparation of the plant and causes over time an ataxic neuropathy that's due to an upper motor neuron disease, and so you get the spastic paraparesis, and amblyopia is also reported with this. This is more of a chronic poisoning manifestation, and as I said again, requires repetitive, inappropriate preparation of the plant. From a management perspective, the number one thing is avoidance and really avoidance of the pits or kernels. So the fleshy part of the fruit is safe to eat, whereas the pits of the species and the kernels in the case of the apricot, those are the things that contain amygdalin and therefore are not safe to eat. If you had someone who was poisoned with this, you could consider giving them sodium thiosulfate. Thiosulfate is a sulfur donor that allows an endogenous enzyme named rhodinase to detoxify cyanide into thiocyanate. Rarely, you could consider the use of standard cyanide antidotes like hydroxycobalamin or sodium nitrite and thiosulfate, but this would require a patient to be extremely seriously poisoned, which is uncommon with plant ingestions. Moving on to our next category, we have the toxalbumins and lectins. So examples of some toxalbumins would be over on the left, ricin or the castor bean, and then over on the right, the rosary pea. These are uh, big proteinaceous toxins, and so I don't have pictures of them because the pictures would not be helpful. But the principal toxin in the castor bean is ricin, and the principal toxin in the rosary pea is abrin. These are alpha beta proteins, so there are two protein chains. The beta chain is what allows for the toxin to enter into the cell, and then the alpha protein chain translocates to the ribosomes in the cell and inhibits ribosomal protein synthesis. You can imagine that that's a problem. Ribosomes are used by the cell to produce protein. Every cell, um, with the sole exception of red blood cells, requires the ability to produce protein in order to accomplish its underlying functions. And so you can get some really serious manifestations with these poisonings. They are typically dependent on the site of entry. So if you get an inhalation toxicity, that generally shows up as the acute respiratory distress syndrome or pulmonary edema. If you have an oral ingestion, that tends to look like a really severe gastroenteritis. These are not well absorbed from the oral route, and often patients still have only this really severe gastroenteritis, even though this is a fairly scary type of poisoning. If you get parenteral exposure, that's when you are concerned about developing this multi-system organ failure. And because of the intracellular site of action, there's really not much that we can do aside from supportive care with this. As an example, for lectins, on the left you have the American pokeweed, and on the right you have the mistletoe. And clinical manifestations for both of those are going to be gastroenteritis is the primary manifestation. For pokeweed, there's this fairly prominent lymphocytosis that is classically described that often lasts for a couple of days after an exposure, but it resolves in most patients without any consequence. And then for mistletoe, rarely you can have neurologic manifestations such as seizure, ataxia, and hepatic manifestation of hepatotoxicity, although uncommon. For all of these, management is good supportive care, IV fluids, and antiemetics if necessary. Moving on to our next class, we have the antimitotic alkaloids, and there are a couple of different things in this category. Over on the left is the autumn crocus. In the middle, we have the periwinkle, the Madagascar periwinkle, and on the right, we have the May apple. There are a couple of different toxins here. Colchicine is the principal toxin from the autumn crocus, and you'll be more familiar with this from its clinical use in things like gout, pericarditis, and familial Mediterranean fever. Vinca alkaloids like vincristine and vinblastine are derived from the Madagascar periwinkle, so you'll be familiar with those and their role as chemotherapeutic agents. And podophyllin is derived from the mayapple. From a clinical manifestation perspective, these tend to follow a similar course. You will early get gastrointestinal illness that's characterized by vomiting and diarrhea. The diarrhea tends to be the more prominent symptom. You will get, in serious poisoning, a leukocytosis followed by leukopenia. And if this progresses into a life-threatening poisoning, the manifestations of that are sepsis, shock, and multi-organ system dysfunction. Again, because we're in a plants lecture, not a pharmaceutical lecture, the more serious manifestations are going to be relatively uncommon with ingestion of the plant material directly. From a management perspective, again, the biggest thing is avoidance, decontamination if you're able to get to the patient before more than an hour or two has occurred. Following that, it's going to be good supportive care, and if the patient develops any of those cytopenias, you're going to consider the use of granulocyte macrophage colony stimulating factor. Moving on to the next category, we have alcohols, and the major constituent in this group is the water hemlock. This contains a poison called cyclotoxin, which is a GABA A receptor channel antagonist. Essentially blocks your GABA function, and therefore you end up with a lot of excitatory problems. From a gastrointestinal perspective, you will have nausea and vomiting, often abdominal pain. Because of excess glutamate or unopposed glutamate activity, you will often end up with vasomotor symptoms like diaphoresis and salivation. And then, as you can imagine, if you are blocking GABA receptors, you are going to end up with seizures. From a management perspective, supportive care is important. And then for seizures or any of those more neuroexcitatory manifestations, you would consider benzodiazepines. Because of the mechanism of action of cyclotoxin, benzodiazepines may not be sufficient, and you may need other agents that bind to different parts of the GABA chloride channel and activate it in a different manner. Those would be barbiturates or propofol if benzodiazepines are not working. Next, we'll move on to the sodium channel poisons. A couple of the substituents in this group would be monkshood over on the left, yew over on the right, the false hellebore over on the left, and the rhododendron over on the right. The associated toxins, monkshood contains a toxin called aconite, which is a sodium channel opener. Taxus, the yew, has multiple different components in it. Taxanes are sodium channel openers, and then the taxanes are microtubule depolymerization inhibitors. I bring that up because Taxus is notable for being where we get or where we initially derive some of the chemotherapeutic agents like paclitaxel from. However, patients with significant U exposures generally don't develop this sort of a toxicity because the sodium channel toxicity tends to predominate. The hellebores contain a compound called veratridine, and rhododendron contains a compound called granotoxin. And then from a clinical manifestations perspective, cardiotoxicity is really the big site of the toxicity here. And you often end up with bradycardia, wide QRS complex, and you can sometimes see ventricular tachycardia, especially with aconite, where you can also see this fairly classic bidirectional ventricular tachycardia. Because of the sodium channel opening mechanism of some of these, you can often end up with paresthesias, and they often come with mental status changes as well. From a management perspective, you're generally going to look towards supportive care. And then in patients that have life-threatening dysrhythmias, you will consider the use of an antidysrhythmic. When looking at patients that are poisoned with aconite, the case series have reported frequent use of amiodarone, which is essentially what you would expect for a wide complex tachycardia or a ventricular tachycardia. A lot of the case series have also reported improvement with flecainide. And so you should consider that a seriously poisoned patient, especially if they're poisoned with a sodium channel opening agent, may require treatment with a strong sodium channel antagonist. However, this should be done in consultation with a toxicologist due to the potential severity of the poisoning if you're at the point of considering that. Moving along to the next group, you have the dermatitis causing agents. Three major plants in this category are all species in the genus Toxicodendron. So you have poison ivy, poison oak, and poison sumac. These contain a compound called urushiol, which causes a rash dermatitis that is a type 4 hypersensitivity reaction. This is often fairly painful, but usually fairly benign. This can be treated with topical lidocaine or topical steroids, or potentially both. In rare cases that patients have inhalation exposure to this, you may need to consider things like albuterol or nebulized lidocaine for management of that. Moving along to oxalates. So there are two primary classes of oxalates. You have insoluble oxalates and soluble oxalates. So on the left, the Dumkane or Dieffenbachia is an example of the insoluble oxalate containing plant. And then on the right, we have the rhubarb, which contains soluble oxalates. These act differently. So insoluble oxalates tend to cause local irritation. That's frequently oral or mucosal irritation, and treatment is generally supportive care. This is often a problem for children who would orally ingest or chew on the plant, and they can actually have a fairly concerning amount of salivation and drooling associated with this. So that sometimes becomes a concern for, an airway issue, but that is still managed in the typical manner for supportive care. And then soluble oxalates, such as what's in rhubarb, often will cause kidney stones, and in really unusually severe cases can cause renal failure. This is by precipitation of the oxalic acid with calcium in the kidney tubules. Moving on to the next class, we have hypoglycin. There's really one principal constituent in this group, which is the ackee fruit or Blachia sapida. This contains a toxin called hypoglycin, which has a couple of different mechanisms of action, all of which end up causing you to be hypoglycemic and have this vomiting sickness. The primary mechanism of action is inhibition of carnitine acyl-CoA transferase, which basically just blocks your ability to metabolize long-chain fatty acids, and then it impacts some enzymes important for gluconeogenesis as well. From a clinical perspective, this causes something called the Jamaican vomiting sickness. So the unripe fruit contains more of this compound, and that causes vomiting, seizures, and hypoglycemia. Management is with IV fluids and dextrose. If there are seizures, you would give benzodiazepines. The mechanism by which seizures are produced is depletion of GABA. And so, in severe cases, you may require a different um, GABA potentiating agent that doesn't require endogenous GABA. So, that would be propofol or a barbiturate. Moving along, the next class are the nicotinic alkaloids. So, we have the tobacco plant on the left, the common broom on the right, the blue cohosh on the left, the laburnum or golden seal on the right, and then I include poison hemlock, along with Socrates for its historical importance. People think that Socrates probably was poisoned with the poison hemlock. A lot of different associated toxins that have a similar mechanism of action. So, nicotine from the tobacco plant, cytosine is the principal poison in the laburnum, spartine from the broom, and then conine from hemlock. These are all nicotinic acetylcholine receptor agonists and produce a similar type of toxicity. It's very common to see nausea and vomiting, sweating, mydriasis, tachycardia, and because of the mechanism, you can get neurologic manifestations as well. Those would be tremor, fasciculation, weakness, including diaphragmatic weakness, and seizures. From a management perspective, you're going to be giving IV fluids to replete volume loss, antiemetics, often benzodiazepines, and in serious cases, you may require mechanical ventilation because of that muscular weakness, which can include respiratory muscle weakness. Um, However, most patients are going to be adequately cared for by just supportive cares. And with that, we will wrap up this very quick overview of some of the most important plants and their associated toxicities. References for the images included are here.